everyone, and welcome to Inside Healthcare. We take a close look today at epilepsy. It's something that even legendary musician Prince said he had as a child. And did you know that civil rights activist Harriet Tubman, whose face you'll soon be seeing on the $20 bill, suffered from epilepsy her entire life? Doctors today now know a lot more about epilepsy and how to treat it than when Harriet Tubman lived in the 1800s, and even more than 50 years ago when doctors diagnosed Prince with it in the late 50s and early 60s. Today, doctors see more than 180,000 new cases of epilepsy each year in the United States, and about 30% occur in children. In fact, children and the elderly are the most affected. Dr. Tassiano Friday with Neuron Neurological Clinic is back joining us to tell us all about epilepsy. Why don't we start first of all, I think there's people don't really totally understand what is epilepsy and what does happen when someone has epilepsy.
Yeah, well, thanks for having me. I think it's a really important topic to discuss because there are up to a few million people in the United States with epilepsy or seizures. And around the world, at least over 65 million people. So that's a significant amount, and so education and recognition of symptoms are very important. So seizures are abnormal electrical activity in the brain. And how we define a seizure versus epilepsy has to do with the number. So epilepsy is defined as 2 or more unprovoked seizures, meaning
that might surprise people.
Yeah, yep. And it has to do with unprovoked seizures, meaning there was no alcohol withdrawal, there was no use of certain drugs such as cocaine, an underlying infection, or a certain cause that could have provoked the seizure. And so that's how you define a seizure versus epilepsy.
So what actually happens in the brain when someone's having a seizure, an epileptic seizure?
Yeah, so how a seizure presents is very different from one person to the next, and really largely depends upon how much of the brain's involved. So a seizure is electrical activity. Seizures, I think it's really easy to understand when you think about it in a prodrome, an aura phase, an ictal, which is a seizure phase, and a post-ictal or post-seizure phase. So I'd like to just talk a little bit about how a seizure might present.
Okay, yeah,
so
what does it look like when someone's having a seizure?
Sure.
Yeah.
So a prodrome phase is an abnormal feeling that people have inside. Something bad's going to happen. Sometimes it's a day before, it can be hours before, but they just have this internal sense that something's not right. And then people can develop what's called an aura, and an aura can be a sensory feeling. It can be certain senses or feelings. So for example, they may have an intense fear out of nowhere, unexplained, maybe a sense of deja vu, like they've been there before. Perhaps it's nausea or this epigastric, this rising sensation, fast heart rate. They might have what we call olfactory, which is a smell, or gustatory, which is taste hallucination. So they might be having metallic taste out of the blue, or smelled burnt rubber, or something rotten, but nobody else in the room can sense that. And sometimes it stops after this aura, this sensory. But it can progress into the ictal or seizure phase. And if the electrical activity is very small area, it's a focal seizure. Okay, and some of the brain is still functioning quite normally, so it can be a little bit more difficult to identify. But what may happen are people may observe the individual staring off blankly. There'll be a change in behavior, maybe a slowness to respond, or a change in speech. Perhaps maybe their arm is having repetitive jerking movements, or they're doing repetitive, we call those automatisms, or repetitive movements like lip smacking, constant fumbling of the hands, pulling at the shirt. So there's a change in behavior. Now, it's electrical, so sometimes it stays focal, but it has the ability to spread and involve the entire brain. And if that happens, that becomes a generalized seizure, a grand mal seizure, in which the entire brain is full of electrical activity. And by definition, then one has lost consciousness and is completely unaware. And the individual may be seen having tightening, tonic posturing, followed by repetitive, aggressive jerking movements. Because they lose consciousness, it's not uncommon to see cheek bites, tongue bites. You can have incontinence or wetting of the pants. And The post-seizure or post-ictal stage then for either one of those is kind of like a stunned brain, an area that, or the brain is not working properly. So they may act somewhat erratic, be confused, not answer questions appropriately. And this can vary. It may be 10 minutes, it can be several hours. And the older we get, sometimes it's a slower response to return back to baseline. But the brain is essentially stunned. So as you can see, there's quite a variety, but the key is a change in behavior. And unique to every individual is their presentation of the seizure. But it's stereotyped, meaning although your seizure could be different from my seizure, for example, it will present in the same fashion with every seizure. So I have something to identify and let me know that the seizures to come, it's stereotyped or the same.
You had mentioned briefly a couple of things that may be triggers, perhaps. What are some of the causes that you see for having an epileptic seizure?
I think that largely depends upon the age. You had mentioned that it's higher prevalence in the very young and the older population. So if we just break it down perhaps by age, in the infants or the newborns in the young age, it can be some trauma during birth. So maybe they're premature and they have blood in the brain, and that acts as an irritant, and so that can cause seizures. Perhaps they were born with a slight variation in their brain or the cortex, and that can be a seizure generator. Perhaps it's just familial or it's a genetic type of epilepsy.
So there is a component to that as well.
There are some types. And then as we move on and we age a little, there can be traumatic brain injuries, sports injuries,
which we've seen.
Infections can occur with any age, of course. And as we then go into the elderly or middle age, new onset seizure, you have to think about other things occurring: stroke, tumors, anything structural that may be the causing the new onset of seizures.
So how do you go about diagnosing someone with epilepsy?
Yeah, there are several steps to this. First is talking to the patient, getting a very good history to try to identify, is this potentially a seizure? And it's hard sometimes for people to articulate symptoms, but trying to put that together for them so you can offer some help and workup.
And is it usually loved ones that can explain it more, or is it sometimes the patient? Just depends, really.
I think it depends, and I actually find both very valuable, and I encourage people to bring loved ones with them or friends that have witnessed, because one might not be aware of certain things occurring, but the observations of others can fill in the gaps and help provide the diagnosis. So a good history, and that's followed then by an electroencephalogram, EEG, and you put little electrodes on the head, and we monitor brain waves, and this helps identify where the seizure could be coming from, if a person's at risk of having seizures down the road. And we also do brain MRIs, which is a picture of the brain that gives us a lot of detail on the structure. Is there anything going on inside the brain that could be causing this seizure?
Some of the tools that certainly did not exist during the Harriet Tubman days and stuff. So, and then once you diagnose them, then what happens?
So then it has to do with, is it the first time seizure? Has there been 2 or more seizures? If it's a first time seizure, we don't always start treatment. It really depends upon what we have found with that EEG and brain MRI. But let's say they've had 2 or more seizures. So medications are really important, and the age, the gender, the type of seizures. This really helps us determine what type of medication. For women of childbearing age, there are certain known seizure medications that are much safer when you're moving forward and thinking about possibility of pregnancy. And then, of course, there's aside from medications, there's other types of treatments that we can do. Ketogenic diet, which is a high-fat, low-carbohydrate diet, which can be useful for some.
And why is that? I mean, do we know why that works?
You know, it's more for types of particular epilepsies, and we tend to do that in the younger population, so we don't always do that so much in the adult population. It's very hard to follow, but it has to do with, there's a different chemical and electrical activity going on with the brain, and we're trying to alter some of this with the things that we do.
And what would that diet consist of?
So it's the nutrition and the physician would work very closely to do that, but it's a very high fat, low carbohydrate diet.
Okay.
And it requires a very rigid diet, so not always the easiest thing to keep within children or as we move forward. Other things which I won't go in great deal about, but there's a lot of information out there about medical marijuana, and we're doing research on that and trying to find ways of using this perhaps to treat medical conditions.
I hadn't heard about that for that particular treatment.
Yep. And if a person has tried and failed 2 or more seizure medications, they are then classified as intractable or refractory epilepsy, which means that they have there are other options available to them. As part of this evaluation, there are some that are surgical candidates, meaning there may be an area in the brain that they could be surgically resected and therefore provide great seizure control. And so if they're a candidate, they would be referred to a surgical center with proper evaluation to see if it's in an area that could be removed and could then help their seizure. If they're not a surgical candidate, or sometimes we use it with a surgical candidate, other types of devices such as the vagus nerve stimulator and the RNS responsive nerve stimulator. So the VNS, or the vagus nerve stimulator, I have a picture down here. And I just want to, I think this nicely demonstrates, it's not a brain surgery. That's one thing that I hear frequently, and it's certainly not. This is an actual device, as you can see. It's not large at all. It looks like a little pacemaker, and it's placed under the chest wall. Similar like a pacemaker. And there's a lead that goes from the device up into the vagus nerve, which is the highway to the brain. And it therefore provides, we program this device with a wand, and it provides electrical impulses very regularly throughout the day, a certain amount on, a certain amount off. So it's always working in the background to try to prevent those seizures from occurring. And there's also a magnet that comes with it, and the magnet looks like a watch. And an individual, remember I talked about those auras, or those funny feelings that they might get, that rising sensations, those funny smells and taste, the deja vu, whatever their particular aura or warning is, that will give them a clue that, ooh, I think my seizure is going to come. They can take their magnet, activate their device, and it will provide an additional, stronger electrical stimulation in hopes of preventing the seizure or making the seizure less severe, so it stops at a shorter amount of time. So this is one type of device, and being able to recognize if a person is a good candidate for this, and again, failed at least 2 seizure medications, and the other is the RNS, which is a device that is put under the scalp within the skull, and it has 2 leads, or a couple leads from this, and it precisely is put in areas where the seizure focuses in the brain, and it monitors patterns. And as the brain starts identifying that, or as this device identifies that abnormal pattern that's very specific to that individual, it will give a stimulation to stop the seizure. So it's a very precise treatment that is now FDA approved and available, and good if someone has seizures coming, for example, from more than one site, so they would not be a surgical candidate. So as you can see, it's really, the field of epilepsy has changed drastically, and there are so many different treatment options. And so getting appropriate evaluation and talking to provider about this for overall safety and treatment options is really critical. I mean, it sounds like it's more, you can live with it and have good quality of life with these treatments and that. Nowadays, with all the treatments we have, people have very good quality of life, and that is something that we really strive for. Some of the medications certainly can have side effects, but it's the individual and the provider need to work together so that the quality of life is good. And sometimes they require more than one medication, different treatment combinations, where this is really unique to the individual, and the epilepsy specialist or the physician, the neurologist, can certainly help guide that. There's also some really important things that I want to mention that not everybody's aware of. But by Minnesota law, a person cannot drive within 3 months of a spell of loss of consciousness or seizure. And that sometimes is very hard for individuals because they feel like they've lost that independence. It makes it a little bit more difficult to travel to and from work. But very, very important, because if a person, the risk of having a recurrent seizure is higher in that time frame, and that's where we've established that 3-month range. And as you can imagine, if someone has an alteration in behavior and their brain is seizing, if they're driving, that can end up in a very unfortunate ending there.
Well, why the 3 months? And why not 6 months or a year or a month or something?
Yeah, it used
why
to be
then?
6 months, and it has now been changed to 3 based on data that we've accumulated with the highest risk of recurrence.
And is that the same for other states as well across the country?
It varies slightly from state to state, but I would say probably a great majority now are 3 months. It used to be 6 months.
So what's the main message that you want to give to our viewers about epilepsy and that they should know about it?
It's very important to talk to your provider, to seek help if there are certain changes in behavior, concerns you have about spells, you don't know what they are, talk to us. We can help you. You can live a very normal life. You can be safe. And that's an important thing so that you have a good quality of life. There are many treatment options, as I've talked about. So it's just being aware of it, educating people, and not being ashamed of it.
Mm-hmm.
I think nowadays we shouldn't be ashamed of it. It's a condition that's very treatable. And some women worry about, can I have children? Can I not have children? Yes, absolutely you can have children. You just need to be in the hands of a provider that can treat you.
So when someone is having in labor, can those sort of stressful things trigger activity like that in the brain?
Yeah, the triggers is a really important question. So aside from non-compliance of meaning not taking your medication on a regular basis, other triggers would include sleep deprivation and stress.
Interesting.
Aside from that, we always look for underlying infections or metabolic disturbances, so sodium being off or your sugars or glucose being quite low, for example. So those can be triggers, and when someone goes to the hospital, the emergency department, those are things that will be checked for on a regular basis. The drug levels to make sure they're taking their medication, or perhaps medications might be interacting with the seizure medications, causing them to be at lower levels. And so those are important triggers. Hormonal influences, so changes that occur during pregnancy, changes that occur perhaps with just our menstrual cycles or with birth control, also very important things to consider when selecting medications and can be potential triggers for seizures.
And I would say another reason not to binge drink or over-consume alcohol, it sounds like as well, that can be a trigger.
Alcohol absolutely can be a trigger, and in particular for certain types of epilepsy. Drugs, stimulant drugs, diet aids, those can be triggers. There are also some prescribed medications which we know can be higher likelihood of triggering seizures, but the providers will certainly walk through that, review the medications, and advise.
So if someone wants some more information about epilepsy or about the clinic or about where they can get some of this treatment and stuff, how do they go about doing that?
Yeah, so if a starting point, you can always talk to your primary doctor who can direct you. Neurologists are certainly very comfortable with treating seizures. We have epilepsy specialists all around the Twin Cities area.
We're very fortunate. Yeah.
Very fortunate. And during clinic, we have several epilepsy specialists as well. The Epilepsy Foundation is a very good website, and I encourage people to use it. They provide a lot of good information about what seizures are, how to treat, resources available to people with epilepsy and families, support groups, lectures, and so Epilepsy Foundation is a very good starting point. But most importantly, talk to your provider, ask questions, and don't be ashamed.
Great advice, and always a pleasure to have you with us. Thank you, Dr. Tassiano Friday. We appreciate it.
Appreciate it.